Good afternoon, and thank you for joining us in Comprehensive Care Transition Support with Jennifer Wagner of Montana. I am Matt. I am with Task at the center, and I am going to be moderating and facilitating this room. So hopefully after this short introduction, you won't actually hear from me again. But if you have any questions or any problems, please let me know. Just shoot me a chat directly, or if you know how to get in touch with me through an email, feel free to do that as well. As always, this session is recorded and will be available for playback about 30 minutes after the session ends in the same place where you joined. Let's see here. You are obviously encouraged to ask questions in the chat or to raise your hand. Jennifer will give an opportunity to ask questions as well. If you are speaking, make sure you take your mic off mute, obviously, or we can't hear you. If you're not speaking, please make sure to keep your microphone on mute. We also like to see faces, so if you ask a question, just turn on your camera for a quick second so we can see who's talking. Other than that, again, if you have any problems, just let me know. At the conclusion of this session, you should be able to summarize best practices in patient discharge communications, identify ways to build a community resource guide, and explain major impacts on discharges and readmissions. Of course, those are the objective for comprehensive care transition support. And at this time, I will introduce Jennifer. Jennifer Wagner began working with Montana Flex program in 2012. Is that correct, Jennifer?
Yes.
In 2012, as the Flex program monitor or the Flex program specialist, her background includes, but is not limited to, experience with MBQIP and data collection and reporting. In her current position of Rural Hospital Improvement Coordinator, she concentrates on developing education and improvement activities for critical access hospital staff. Jen received her Certified Professional in Healthcare Quality credential in 2019 and is currently pursuing her bachelor's degree in public health. Jennifer, we are happy to have you here, and we are excited to hear what you have to share. And at this point, I will let you take it away.
Awesome. Thank you so much, Matt. And thank you to everyone for sharing your time with me today. Before we start, I just want to give a disclaimer that I am in no way an expert on discharge planning, readmissions, or technical pieces of this project, but I am really good at project management, and this is what our experience boiled down to. So today I'm going to share with you how we facilitated a project on care transitions and the tool that resulted from that project. We already went over today's objectives, so I'll go over that, skip over that really quick. To start out with, we have an improvement project framework that's called MBQIP to Outcomes, or M2O. And this is the project framework developed a few years back by the Montana Flex program to address MBQIP quality improvement implementation. The project for 2020 was the start and the foundation of the toolkit that I will demonstrate for you later in this presentation. Our 2020 project improvement goals were care transitions, discharge planning, and readmissions, as they're all interrelated. You'll probably notice by the year listed, this project happened in the middle of a pandemic and kicked off about 2 months after I was into my role. So there was a lot of moving parts and changes and learning for everyone involved, but it turned out to be a really fantastic experience. We have 49 critical access hospitals in Montana, and 21 of those hospitals signed up and participated in this project and stuck through all the education sessions. This slide just breaks down our hospital participation in size by net patient revenue. It's a really good visual to see that we had our biggest hospitals and our teeny tiniest hospitals all working together on this and informing the work that we did during the project. When starting the project, we asked our hospitals to come committed, willing, and excited to share with their peers and to work on this. I feel like a lot of times in our quality improvement projects, they're just checking off boxes. And so we're trying to bring that excitement and passion and commitment back to the projects we're working on. We asked that all the data collection was complete and that they attend and participate in virtual sessions. These virtual sessions were actually a benefit and were a change from the past where we had a mix of in-person and virtual, because the whole team could participate and share, not just the quality coordinator that they could send to a conference, but everyone that's doing the work and involved in the work could share. Our virtual sessions allowed time for hospitals to share their progress, wins, frustrations, questions, and has been reported as one of the highest values of our project. The objectives for this project were to identify gaps in discharge processes, help hospitals collect and communicate information with the patient and patient representative, work on a list of services and capabilities for each facility and their surrounding area so that we could help address options and needs after they were discharged. And then, of course, to reduce readmissions through better discharge practices and improved communication. The project was formatted with a pre-project data collection that was designed and based on the ARC Hospital Guide to Reducing Medicaid Readmissions Toolbox. We had 60-minute webinars every 2 weeks that included delivery of specific education and discussion. And after each webinar, we asked the hospitals to identify a small test of change that they could take and implement in the next 2 weeks, and then report back that to us. So we had that accountability built in. And we encouraged all staff involved in the process to attend. This was crucial for buy-in and productivity of the implementations. And each session had, like I mentioned, built-in time to share, collaborate, and network with other hospitals working towards their similar goals. We provided a series of education sessions by Cynosure Health. We had education on data analysis, the model for improvement, small tests of change, and then getting into specifics on transitions of care flow, what can be the root cause of a readmission, how to get buy-in and support in the facility, and then teach methods and scripting for HCAPs. So for our data collection for this process, my predecessor had taken the AHRQ guide to reducing Medicaid readmissions and put those questions and metrics into an Excel data sheet that was used for baseline collection. Since I kind of took this on just as it was rolling out, we went ahead and used that. But in the process of getting that baseline data back, we discovered that some of the pieces in this ARC guide are not a priority or really applicable to critical access hospitals. So we made some changes and identified the 3 metrics here for our baseline and remeasurement metrics. We looked at HCAPs scores for the care transitions composites, readmissions, and put together a conditions of participation and best practice self-assessment that uses best practices noted in the ARC guide and found other places, as well as discharge planning COP requirements from CMS. So the first piece we looked at was identifying gaps for the conditions of participation. And this is just an example of some of the data we pulled out of the cohort. Shown here are the 10 assessment items in which the fewest members of the cohort met. So that's how we identified where to start with education and encourage them to use this to identify where to start in their performance improvement. For example, 39% of the 20 cause in this project used an evidence-based screening method for screening patients. And so that was super easy to address because we were able to provide links and make connections.
Good, how are you doing?
And at our remeasurement period, 73% of the hospitals had used that evidence-based screening method. So I just wanted to show that to just show you how small the problem was and easy to address, so we could just check it off and provide that support. The next set of data on readmission details, our baseline data collection for readmissions was really lengthy. So in the process of this, we pulled together all the readmission data and we presented it to the hospitals. And then we worked through each measure to see what pieces of data actually tell us something, and more importantly, what can be actionable or trending. This is where I will say, as a person in a coordinator role, my lack of specific technical experience in this was really helpful because not being in the actual work, I didn't have the, oh, we just do this because we've always done it this way mentality on some of these things, but really drill down to why are we collecting it and what exactly is it telling you? And if there's no action we can take on it and it's not telling us something important, let's kind of move that off to the side and not spend time on it. So the metrics for readmissions that we drilled down to was the patient's discharge disposition, the day of the week that they were discharged from the initial visit, the number of days between discharge and readmission, condition and diagnosis, and what discharge planning and documentation processes were complete. We next put in the concept of readmission interviews. This was new to a lot of patients, or not a lot of patients, a lot of hospitals, and it's really a goldmine of information because it's directly to the patient, drilling down the whys to a root cause and helping understand why they feel like they came back and not just using a medical record or medical terms. We then focused on staff buy-in and skills practice. Even though we had everyone that was available at the hospital that was doing the work involved, there was still some hesitation to implement things. And so we provide some coaching to our group of hospitals on how to get buy-in, how to connect them, who to identify and engage as champions, how to communicate, and how to align the work. We also practiced teach-back and scripting, in which we did a video contest of teach-back methods and scripts, and participants that sent in videos or recordings were sent a leadership book, and we viewed these during one of our meetings. It was a lot of fun and something to kind of break up the tedious work. We also want to look beyond the discharge. Social determinants of health are a very real thing. And what happens to the patient when they are discharged really affects if and how they're being their readmission and their success for recovery. So hospitals should have an understanding of the needs of the patient outside of the hospital when they're discharged and what's available in the rural area that can meet those needs. To inform this, I reached out to our state health improvement plan lead, and she gave an overview of social determinants of health. And then she made connections with me to the resources listed here. Now, these are Montana specific resources, but I'm sure there's similar ones, similar topics in each different state that can be touched on. But this is just our Montana ones here. And so we scheduled a series of calls with about 2 or 3 resources per call for those individuals to explain their work and how to use their resource. And this was very valuable in having that direct communication with the organization and seeing how the resources work. We were able to complete a remeasurement period for this project. And the data isn't completely what we wanted to see. However, we have this big outlier of COVID. Fourth quarter 2020 is when we saw our highest influx of COVID cases and hospitalizations in Montana. And so though I believe that can't help but inform those readmission rates and HCAP scores, I would like to monitor and revisit the data during a time of normal volume for hospitals where they aren't completely at capacity and they have like normal workflows. But what can be seen is that despite all of this, the hospital still worked on implementing those best practices and meeting conditions of participation. We went from 76% of meeting the 56 elements that we had to 90%. So that was really encouraging as we went on. So that's kind of the story that how this toolkit was built. And so I'll go over what we built out of this project. The most recent version of this toolkit can always be found at this link here. Didn't mean to click there, on our website. And I can put that in the chat in a minute here. And we are more than happy to share this file with flex programs and organizations outside of Montana, and just ask that the credits and citations on the table of contents tab remain. So, you know, most importantly, we drew from a lot of great resources. We want to make sure those resources receive the credit they deserve. This tool is not required to be used in its entirety. Bits and pieces can be used per the hospital's specific needs, or the whole thing can be used. As I mentioned before, most aspects are based on the ARC toolkit, but are refined extensively to meet the wants and needs of our Montana hospitals. And we added some additional information screens for hospitals to share internally for education. So right now, I will kind of walk you through what we developed and how it works. So the first tab is our table of contents. There's 16 other tabs in this toolkit. So the table of contents is really important and is color-coded and divided by topics. And each tab is hyperlinked here in the table of contents. So we have topics of regulations and best practices, screening and assessment flows, or assessment and evaluations, communications, and data. So to show you how it works, we'll just start by walking through with the regulatory section and clicking on regulations and best practices crosswalk. So the first iteration of this was used as that gap analysis that we did with the hospitals, and then we built it into a more usable tool. So it still functions as a gap analysis. The template tool comes with column C here cleared, and so a hospital would just fill in yes or no if they meet this practice. And then it's also tied to what else does this practice inform? Is it a COP requirement? Should it be in an evaluation? Is it part of communications? And could it potentially affect the HCAP scores? We were able to identify resources, so it's not just information. Where we could identify resources, we have them linked here in the resources tab, or the resources column. In the next sheet, we have a screening and assessment flow. This is taken from the New York State Department of Health. We have initial discharge screening questions, and then your comprehensive assessment triggers, and then what that comprehensive assessment looks like. This is designed so that the hospital can take this information and put it in a format workable for them, as are all the other tabs and resources in this tool. But it's helpful having that information in one place. And then there's a fantastic flowchart that the New York Department of Health built to show when and how these assessments and screenings take place. So we have two resources for discharge evaluation. We have discharge evaluation and then admission evaluation to a nursing home. The flow of information is incredibly critical, and I don't really think that much should be left to assumption by medical providers, the patient's family, or even the patients themselves. The discharge evaluation and the evaluation to nursing home are templates designed to be reformatted, and the goal is to provide a roadmap of communication pieces that should be included to promote a successful discharge. The nursing home one is slightly different, as there are some specific information pieces that nursing homes find very valuable, and we built that piece with our quality improvement organization here in Montana and their nursing home team there. So as I mentioned, this one's just a little different, and it has some different information that a nursing home would need when they're getting a patient back. We have similar outlines for patient and provider communications. what information should be sent to whom and what that information is. Having that consistent across all communication levels is super important. And like I mentioned, you can't assume what the patient or the patient family knows, will remember, or even understand. So having that information summarized and in writing is valuable to everyone. So the provider next level communications has those pieces that a provider needs, and is informed also by the conditions of participation, and same with patient communications. And again, these are just layouts and guides that can be done in a different format for the hospital, or can be entered into the EHR, whatever works for them. So now that we have a patient that's getting ready to discharge, we want to look at what they might need after they leave the hospital. And so that's where building those resource guides and addressing the social determinants of health come into play. So this is a guide on how to build your resource guide. We listed what community information that we pulled and the description of that. So if you're wanting to look at similar ones in your state, you can use this to start that research. And then this information will inform the guides we'll show here in a second. So here's your facilities and service capabilities list, and it just has everything that the hospital can provide. And then the community resource guide is the same idea for that community. Both guides need to be reviewed and updated on a regular basis if they're going to be recorded in this formatting. Another option is for especially the community resources, is to document where the database resource is available. Like if my community-based social workers can be found at the Montana 211 site, just link that there and then go to the site to find it. Each time, there's often a lot of turnaround or turnover, and so we want to make sure that everything we can do to mitigate errors and misdirection of people. So whatever works best for the hospital, that's perfectly fine. After the patient is discharged and now they have what they need outside of the hospital for when they come for follow-up and what they can access in the community, it's time to do a discharge follow-up call. Prior to discharge, there are some questions that should be asked to help increase the value of the call. The first is, when is a good or bad time in general to call? If they have, patients might have a standing social commitment or a favorite television show. And also with cell phones and the increase of scams, let the patient know what number they can expect a call from so that they are more likely to answer that call. These scripts are all from the Project Red resource, and will just help guide a conversation on how the patient is doing at home. And hopefully addressing these issues, being able to identify any issues will help prevent that readmission. This is also an interview form and script, just again, can be used in whatever format works best. But setting up for success when you're doing a readmission interview. And so, as I mentioned, this was a new concept for a lot of our hospitals, but the readmission interview, what is to be done during the readmission stay, it's not a call afterwards, and it's a gold mine of information to get to really why that patient was readmitted into their own words, because they might not understand that they were even readmitted. They just knew they were sick and had to go to the hospital. And so we have some notes and tips. The interview script and steps are sourced from the Spire readmission interview tool. You can see we resourced a lot of things and just put them together in one area. There's so much incredible work out there. There's no use in duplicating it. It's just helping kind of narrow that resource funnel so that it's not as overwhelming. Factors in readmits, this is an informational slide that hospitals can use to communicate how important it is to address the really, really lengthy back factors of readmissions. Not only is there 6 categories, but there's subcategories in each one that will affect a readmission. So it's a very holistic thing to look at and a great visual for hospitals to use internally as to why working on readmissions and discharges is really important. Next, we have our readmission data entry. So this is information at the patient level that helps us identify why we might have a readmission. So it's designed to be redacted, and this is just some test information here. And the data in this sheet will then be populated into charts and graphs on the readmission data evaluation tab. We have a built-in drop-down menus that are built in the lookups tab down here, and in the lookups tab there's instructions on how to use it. So if someone isn't feeling very competent, or it's kind of feels like a more advanced Excel skill set, there's information and support there. But we track our primary care provider, the patient age, the payer, discharge time of day, so we can identify if there's issues with shifts, the day of the week, who the initial visit primary provider was, and then who the provider was that discharged. Is it the same provider, or is it a provider that's just discharging everybody before they're ready to go out? This was super hard to graph, and my skills don't allow me to graph it. So we have it color coded. If the provider is the same, the field turns green. And if it's a different provider than the one that was there when they initially were admitted, it stays blue. We want to look at our initial visit primary diagnosis, and then here in the gray readmissions, we'll look at the readmit visit primary diagnosis to identify if it's same or all cause. We look at the initial visit length of stay. Did they stay long enough, or were they discharged too soon? And where that location was to, and then where they went afterwards. Most of the fields that can be calculated are calculated, such as the number of days between discharge readmission. However, when looking at the readmission, same in all cause, there's not really a formula to identify that. So that is one piece that needs to be looked at specifically. And then we have our evaluation of discharge best practices. So if this patient was readmitted, at the initial discharge, did we follow our best practices, or is there something we're missing that might help keep patients from being readmitted? And then we have our readmission data evaluation tab that takes the data you just saw and puts it in charts and graphs to be used. It's auto-populated, and there's also some information that is included in tables that just weren't very cleanly graphable here. As I mentioned, the dropdowns are all based in this lookup tab, and we have information on how to manage those for those that might not have that level of Excel experience. So that wraps up this really extensive toolkit. And before I conclude, are there any questions on how it's used? Any questions on the project? And if you would like a copy, we will, you can email me at jennifer.wagner@mtha.org or visit our website. I have it pulled up here. This is this is our care transitions page, and the care transitions toolkit is here, and that's where the most recent version will live.
Hi, Jennifer, this is Christy Martinson. Can I ask a question?
Yes, absolutely.
Thanks so much for that great presentation. It's such a cool program, and I'm so amazed at that toolkit, which I'm sure took so much time to put together. I joined a little late, so sorry if you already covered this at the beginning, but I was just a little interested if you could talk a little bit more about what you did to get providers to start using this tool, what challenges or lessons learned you had there.
So it's mostly our quality coordinators that are using the tool, and then the discharge planners. Not so much the hospital providers. It's really new being used, so I don't have a lot of feedback yet on how they're using this and what the response has been within the facility. We are doing a little mini project this month, and on like readmissions for chronic diseases. We're calling it a sprint, and we have hospitals that are using the tool as their data collection. So that has been really helpful and encouraging to see.
Thank you.
Thank you. So we have 10 minutes left. I don't know how mad task will be if we adjourn, but please, if you have any questions, I'm happy to.
We're going to be furious. I'm just kidding.
Am I going to be like kicked out of the Flex program?
Does anybody have any questions, comments, concerns, dedications, complaints, or anything about this session for Jennifer? You can type them in the chat box or just speak up. Or if you have any questions concerning anything else that has already occurred today that maybe I can answer for you or anything like that, now is a good time to take care of that as well. If not, then yes, we are fine, Jennifer, with wrapping up a little bit early. So we do have a little bit of a break on the schedule. Let me pull that up right here. I say that, and of course I don't have it pulled up. So we do have a little bit of break, and then the next section is a plenary session here this afternoon at 2:40 on how to support value-based care as a state flex program. That will be with Terry Hill and Caleb Siam with the center. And then of course we have networking rooms available after that as well. We hope that you are using those networking rooms. From what I hear, they've been interesting and fun. So we appreciate that and appreciate y'all's feedback and involvement in that. So are there any other further questions? All right, well then, Jennifer, thank you so much for being here. Great content, great data. We appreciate you and your hard work over there in Montana. And we look forward to seeing you guys here at 2:40. And if there's anything we can do for you, don't hesitate to reach out.
Wonderful. Thank you, everyone, for your time and attention today. I appreciate it.